Uh, Good afternoon. At the outset, I would like to thank Dr. Sita, the organizers, for inviting for this meeting. So, uh, as per the new, the latest UEG concerns of the European societies, including UEG SPGAN, exocrine pancreatic insufficiency is defined as a reduction of the pancreatic exocrine secretion and or interluminal activity of the pancreatic enzymes below a level that permits normal digestion of the nutrients. So this is the new addition, what is underlined. And the intestinal symptoms and nutritional deficiencies are the main clinical manifestations and consequences. So these consequences may have an impact on the quality of life and also may put the patients at risk of long-term malnutrition related complications. This is from the guidelines actually. So that's why it is important to have a assessment of the exocrine pancreatic insufficiency. So this is a rough guide to the prevalence of EPI according to the etiology. So at the diagnosis of chronic pancreatitis, so early it would be about 10%, and after about 10 to 12 years of the disease, it can range from 60 to 90%. And in acute pancreatitis, in the short term, it could be 60%, and the long term about 30%. And pancreatic tumors also, it is higher for unresectable tumors, and that's different rates for before and after surgeries. And depending on the type of surgery, you can have the prevalence of the exocrine insufficiency can be higher. So when you know the disease you are dealing with, the pre-test probability of the test you are going to use automatically is higher. So you can have an idea of how reliable your test reports might be. So this is a overall view of all the tests that are available. We know traditionally there are direct tests, which are the ones which are stimulatory, and we assess the bicarbonate secretion and the enzymes. We have the secretin test, we have cholecystokinin test, and you have a combination of secretin and cholecystokinin test. And you have some variations in which you can do a ERCP and directly collect the secretin also. And you have the meal stimulator test, which are less invasive, and you have the indirect test, which include fecal fat, fecal chymotrypsin, fecal elastase, and the breath test. So as we know, the gold standard for is the direct secretin pancreatic function test. And most centers use a direct secreting, most of the tertiary centers which would be having a research focus would be using this test. Some of the centers prefer the cholecystokinin test, and some would use the combination also. So this has been classically considered as the gold standard for diagnosis of EPI. However, there are practical issues because it's quite invasive, and because of that, and it's less used now and less available. However, for the from the diagnostic point of view, it is for picking up early pancreatic insufficiency in early chronic pancreatitis. It is the most sensitive among all the tests so far. And fecal fat excretion, that is, you have a 72-hour fecal fat excretion and the coefficient of fat absorption. This is the gold standard for diagnosis of steatorrhea. CFA is mostly used in all the pharmacological trials for pancreatic enzymes, comparing with the placebo. So in view of the difficulties in direct testing using drilling tube and other oral drilling tubes, some of the centers have come up with a variation that is endoscopic pancreatic function test, in which you use endoscope, and it has been shown that the results are not affected if you use sedation or analgesics. And it has been shown to correlate with the conventional direct test, but in healthy subjects. To my knowledge, there is no trial, no study which has compared the endoscopic pancreatic function test with the drilling tube in chronic pancreatitis. So it is more widely available and easy, and it's less uncomfortable when there is no radiation involved. But the traditional drilling test would be a 1 hour. So because of the practicality of a 1 hour endoscope, occupying endoscope room, there are now we have 30 minutes or 45 minutes is sufficient according to some of the those who are using this study. So this is one approach in which you would initially do an endoscopic ultrasound to assess the pancreas, and then switch to the gastroscope. And total endoscopy time would be about 35 minutes, in which you can do about 45 minutes of the aspiration. So this is a shorter variation of the endoscopic test, which is used in some of the centers. But to my knowledge, it's not very popular still yet among us. So among the newer tests, we have pancreatic elastography. So this is one study which came in the Red Journal in 2022, which showed that this also predicts the endoscopic the pancreatic exocrine insufficiency. So this has been in which they used that as a gold standard. So they found that the correlation between the EOS strain ratio on EOS elastography and the endoscopic pancreatic function test, they found that it was a 93.4%. So that is, so this suggests that this is also a promising test and might be used with more studies to validate it. So coming to fecal fat excretion, so as we know that we have qualitative test, semi-quantitative and quantitative test. So basically fat globules, so normally to pick up Sudan 3, Sudan 4, at least 25 gram of fat excretion is, has to be there. So it is not very sensitive in that way. And we know that the appearance can be missed with, can be confused with the parasites also. So the gold standard, as we have already mentioned, is the fecal fat excretion and the CFA. So in this case, we have a standardized diet and we collect it and it is done for the fecal fat excretion or the total fat excretion. And the CFA measures the fat absorption efficacy, and the normal CFA is about 93% of the fat content. So the practical issue is that this has to be done as an inpatient test. It is not feasible to do it as an OP patient, as an OP test, because on outpatient basis, collecting the feces, storing refrigerant is too much to expect the patient to bring it from home and collect it and refrigerate. And secondly, the diet has to be monitored, and you have to, that's why it is also not much used in normal clinical practice. So that is the basic outline of how it is done. And the fecal fat of more than 7 gram is steatorrhea, and more than 14 would be definitely receiving PRT. So this is another test, acid steatocrit, which is also not really a quantitative test, but it was tried out in some centers. And value of less than 31% is considered normal, and more than that is steatorrhea. So among the, if you see the indirect pancreatic, the tubeless test, so this is the sensitivity as compared to the direct test. So coming to fecal elastase, which is the most widely used, this is simple, non-invasive and relatively inexpensive. And as you know that it can survive interstitial passage, and it is not affected by exogenous use of enzymes. And we have both the monoclonal and polyclonal ELISA. So less than 200 microgram per stool is considered abnormal, and less than 100 is more consistent. And most of the general consensus is that less than 50 is very reliable for severe exocrine insufficiency. So this was our study, which is the first study we did in India, in which we had done elastase and acid steatocrit. It was published in 2009. And we found that 53% of the chronic pancreas patient with a normal BMI had low elastase. So it is, we did feel it was a useful test to pick up early evidence of EPI in chronic pancreatitis. Okay, I'll skip this for time being. So this is a systematic review and meta-analysis published this year in the UEG journal for the diagnostic accuracy of elastase in EPI. So this is the first meta-analysis which has used the new definition of UEG. And the conclusion is that it is highly sensitive, that's about 94%, but it is moderately specific, that is 69%, using the standard 200 microgram per gram cutoff. So due to the moderate specificity, the fecal elastase should be interpreted cautiously in the low risk settings, and you should integrate the results with the clinical context and also have an assessment of the nutritional status. So this is one preliminary report of is published in an abstract in which they have done a newly developed lateral flow assay of elastase. So this is what they call a point of care testing of elastase. So you get the result in 15 minutes. So something like this with more validation, this type of test would be useful to do a point of care elastase test. So coming to breath test, we have the C13 mixed triglyceride breath test. This is the most widely used breath test. It has replaced the earlier trialine other breath test. And we know that after the ingestion of a C13 labeled mixed triglyceride, you have after a process of lipolysis, absorption, and the oxidation, the 13 carbon is excreted as exhaled as a 13 carbon CO2. So coming to the accuracy of this test, this is in 2007. This shown that it was a good test for compared with the other tests, and it is quite accurate to also affect the effects of enzyme therapy. So one of the use of this test is you can use it to monitor people who are on PRT and assess the results of the enzyme therapy. So this is another systematic review for the accuracy of C13 in evaluation of pancreatic function. So in this, they assessed 37 studies, and they found that it is definitely a useful test, and there is some refinement needs to be done with the test to make it more widely used. So for example, this is the general consensus that it should be done as after pre-test overnight fasting, and the test meal should have at least 10 gram of lipids, and it should have able to control the exercise and dietary intake. 30 minutes of breath samples is every 30 minutes, and there is no point doing more than 6 hours. Usually up to 5 hours is what is done, and isotope ratio mass spectrometry is preferred for the analysis part. There is some confusion regarding what should be the ideal test meal and what should be how long you should stop PRT before doing this test. So probably the general feeling is that with some modifications, this test could become more widely used and more popular. To summarize, clinical measures, that is the stool frequency, the appearance of the stool and consistency are subjective, and it need not only be due to EPA. So the direct measures, while being very sensitive, still now are impractical for being invasive and difficult to use. The tubeless alternatives like bentonite test and pancreatic test are not effective substitutes and have become obsolete. So 72-hour fecal fat estimation is still the gold standard, but it is quite unpleasant use in the clinical setting. And the steatocrit test is also not very quantitative. And Sudan 3, as I already mentioned earlier, it's very non-specific, and you cannot pick up early EPA. So the other option of using the response to a therapeutic trial of pancreatic enzymes is also unreliable for diagnosis of EPA, because other non-pancreatic conditions also may respond to therapeutic trials of enzymes. So with the available test for clinical use, fecal elastase is the most appropriate initial test. And the present approach is to identify the risk group. When you have definite EPI, that is you have a setting of severe pancreatitis or malignancy, and you don't actually need a diagnosis, you can initiate on PRT directly. When you have a EPI possible or unlikely, then you need to have a diagnosis of EPI. So you should combine it with the clinical context and also assess have a nutritional assessment, and with this, they should interpret the results of the fecal elastase test. So coming to the AGA best practice advice, high risk conditions like chronic pancreatitis, acute pancreatitis, recurrent acute pancreatitis, cystic fibrosis, ductal adenocarcinoma. Moderate risk conditions are dual disease, long-standing diabetes, type 1 diabetes, and other hypersecretory states. So fecal elastase is the initial test. You should interpret it with the clinical context. If you are in the setting of a pancreatic disease, you should need appropriate cross-sectional imaging, and the invasive or the other invasive pancreatic test can be done only in limited centers as required. Thank you.